Treatment of cerebellar motor dysfunction. Teresa Azesiewicz, MD Fawn. Director, USF Ataxia Research Center. University of South Florida, Tampa. Treatment of cerebellar motor dysfunction, cerebellar ataxia. The cerebellum, structure in the brain that is paramount in maintaining balance. Connections to other areas of the brain, including the thalamus and the cerebral cortex. Connections to spinal cord. Cerebellar dysfunction. Visual problems, nystagmus. Dysmetria or past pointing. Difficulty with heel-to-shin tests. Dystotochokinesia, rapid alternating movements. Ataxia, staggering gait, in which the patient is unable to perform a tandem or heel-to-toe walk. Abnormal stance and wide-based gait. Ataxioprevalence. One Japanese study found ataxioprevalence to be 18.5 per 100,000. In Norway, 6.5 per 100,000. Other studies, 5 per 100,000. All ataxias taken together, highest range may be 15 to 20 per 100,000. Clockgether et al. Diagnosis. Neurologic exam to differentiate between cerebellar and sensory ataxia. Document findings. May perform scales to rate cerebellar dysfunction. Ask about family history, cerebellar degeneration. Most common form of acquired cerebellar degeneration is alcohol. Affects lower limbs, with gait disorder. Mondo and Marmolino. Degenerative ataxias. Autosomal dominant ataxia. Parkinsonism, multiple system atrophy C, or cerebellar. Autosomal recessive ataxia. X-linked. Sporadic, idiopathic ataxia. Acquired ataxias. Stroke toxic, ethanol. Drugs, antiepileptics, lithium, some chemotherapeutic agents. Heavy metals. Solvents. Immune-related. Infectious. Mondo and Marmolino. Acquired ataxias. Traumatic neoplastic endocrine. Structural disease, dysplasias. Multiple system atrophy, atypical Parkinsonism. Most common non-hereditary ataxia. Parkinsonism with other features, including orthostatic hypotension, drop in blood pressure upon standing, imbalance. No treatment for underlying cause. MSAP and MSAC. Immune-mediated cerebellar ataxia. Multiple sclerosis. Stiff person syndrome. Gluten. Miller-Fisher. Lupus. Thyroiditis. Paraneoplastic cerebellar syndrome. Mono et al. Episodic ataxia. Episodic ataxia, EA, is an autosomal dominant disorder characterized by sporadic bouts of ataxia, severe discoordination. Myochemia may be present. Ataxia can be provoked by stress or startle. Can occur in infancy. Mutations of the gene KCNA1, which encodes the voltage-gated potassium channel Kv1.1, are responsible for this subtype of episodic ataxia. Autosomal dominant ataxias, spinocerebellar ataxia. 30+ SCA types are known. SCA1, SCA2, SCA3 and SCA6 represent the most frequent SCAs worldwide. The prominent disease symptoms of the currently known and genetically defined 30+ SCA types result from damage to the cerebellum and interconnected brain grays and are often accompanied by more specific extracerebellar symptoms. Positive family history. Dominant, spinocerebellar ataxia, episodic ataxia. Different SCAs have different phenotypes. For example, SCA5 and 6 are purely cerebellar. SCA 1, 2, 3, 12, 17, 21 have associated Parkinsonism. Pathophysiology of SCAS. The most frequent sites of neurodegeneration: cerebellum, thalamus, pons, midbrain. Different SCAs usually overlap considerably in advanced stages. Spinocerebellar ataxias. Autosomal dominant ataxias, numbered in the order in which they were discovered. Seizures occur in SCA types 10, 17. Downbeat nystagmus, SCA 6. Pigmentary retinopathy, SCA 7. Ocular dyskinesia, SCA 10. Dystonia, SCA 3,14, 17. Myokemia, SCA 5. Many SCAS are marked by pyramidal signs and peripheral neuropathy mono and marmelino. Spinocerebellar ataxias. SCA 1,2,3, ataxin, gene product. SCA 6, calcium channel subunit. SCA 14, potassium channel subunit. SCA 5 and 6, almost pure cerebellar ataxia. SCA 4, ataxia, sensory neuropathy. SCA 1,2,3, ataxia, pyramidal signs, neuropathy, RLS, Parkinsonism. ASARS. Autosomal dominant ataxia. Athena Diagnostics now offers tests to diagnose many of these diseases, blood tests. SCAS generally begin later on in a patient's life, 40s or 50s. Alternatively, autosomal recessive ataxias usually occur in early life. Both are progressive. Falls and swallowing problems, urinary issues. Controversial issue regarding Lincoln's ancestors and SCA 5. JPG. SCA 5. SCA 5 is sometimes called Lincoln's ataxia because a 10-generation family with the condition has ancestries that trace to the paternal grandparents of President Abraham Lincoln. SCA 5 also is sometimes called Holmes ataxia after Dr. Gordon Holmes. Autosomal recessive ataxia. Friedreich's ataxia. Abnormality of protein frataxin. Gene locus 9q13. Others include abetalipoproteinemia, metachromatic leukodystrophy, Niemann-Pick, Wilson's disease, Refsum's disease. Autosomal recessive ataxia. FRDA. OA2. Ataxia telangiectasia. Marinesco-Sjogren. Charlevoix-Saguenay. Vitamin E deficiency. Nicolas Friedreich, 1860. Friedreich's ataxia. Mutation in gene that codes for frataxin, located on chromosome 9. This protein is essential for mitochondrial functioning. Frataxin absence leads to iron buildup. Free radical damage. Antioxidants and ways of increasing frataxin are being researched. Friedreich's ataxia. An expanded guanosine, adenine, GAA, triplet repeat, first intron, in both alleles of the frataxin gene occurs in 98% of people with FA, Pandolfo, 2012. The length of the GAA repeats correlates with the age of onset, progression, and severity of the disease. Friedreich's ataxia. Symptoms typically begin sometime between the ages of 5 to 15 years. Muscle weakness in the arms and legs. Loss of coordination. Vision impairment. Hearing impairment. Slurred speech. Scoliosis. Diabetes. Cardiomyopathy. Friedreich's ataxia-pathophysiology. The posterior columns and corticospinal, ventral, and lateral spinocerebellar tracts all show demyelination. The dorsal spinal ganglia show shrinkage and eventual disappearance of neurons associated with proliferation of capsular cells. The loss of large neurons in the sensory ganglia causes extinction of tendon reflexes. Friedreich's ataxia cardiomyopathy arrhythmias. Even if ejection fraction is within normal limits, there are cardiac abnormalities. Diabetes and issues with carbohydrate metabolism. Follow HbA1c every year. Echocardiogram every year, as well as EKG. Immune-mediated cerebellar ataxia. Multiple sclerosis. Stiff person syndrome. Gluten. Miller-Fisher. Lupus. Thyroiditis. Paraneoplastic cerebellar syndrome. Mono et al., FCSTAS, X-linked, fragile X-tremor ataxia syndrome, FCSTAS. Older males, often family history of fragile X mental retardation in a grandson. Parkinsonism. Postural tremor. Imbalance. Can be confusing if you see patients who have Parkinsonism, what appears to be ET and ataxia. Acetylcholine, nicotinic receptors. Physostigmine, early work in ataxia. Physostigmine acts by interfering with the metabolism of acetylcholine. It is a reversible inhibitor of acetylcholinesterase, the enzyme responsible for the breakdown of acetylcholine in the synaptic cleft of the neuromuscular junction. It indirectly stimulates both nicotinic and muscarinic receptors. Physostigmine Kark et al., 1981, 28 patients various inherited ataxias. No validated tool, no baseline characteristics besides ataxia, no allocation concealment. Videotape assessments. Responders and non-responders. Very low dose of physostigmine. Drug was more effective than placebo, p less than 0.05. Physostigmine Vessel et al. Physostigmine patch did not have any benefit. Monium had a DB crossover trial, also found negative. All studies suffered from poor inclusion criteria, lack of validated tool. Varenicline 2012. A randomized trial of varenicline, Chandux, for the treatment of spinocerebellar ataxia type 3. Varenicline is a partial agonist at alpha-4 beta-2 nicotinic acetylcholine receptors. 20 patients with genetically confirmed SCA3 were randomized to receive varenicline 1 mg BID or placebo. DB, randomized, placebo-controlled trial. USF, BI and UCLA. Varenicline outcome measure was the SARA, timed 25-foot walk. The most common side effect encountered was nausea, vivid dreams. There were significant improvements in gait, stance, rapid alternating movements, SARA, and timed 25-foot walk. Beck's depression scale improved in these patients significantly. FDA Orphan Drug Program. Varenicline improvements were significant for axial function. Only rapid alternating movements improved for appendicular function. Idea is to find a drug that works on the nicotinic acetylcholine system with fewer side effects than varenicline. Study results intended as a crossover study. However, very high placebo dropout rate, urosepsis and muscle pain, non-compliance. Average dose, 1.67 plus minus 0.50 mg/day. Significant improvements in gait, p equals 0.04, stance, p equals 0.03, RAM, p equals 0.003, and timed 25-foot walk, p equals 0.05. A's, nausea, vivid dreaming, leg tingling. Nicotinic agonists may confer improvement by a combination of actions initiated at different subtypes of neuronal receptors. varenicline, alpha-4, beta-2, but full agonist activity at alpha-7 receptors and weak partial activity at alpha-beta-2 and alpha-6. Activity at alpha-7 and alpha-4 beta-2 receptors, stimulation, protects glutamate-induced motor neuron death in rat spinal cord cultures. Glutamate. Riluzole-Ristray et al. 2011 DB, randomized, placebo-controlled trial. Riluzole 100 mg/day for 8 weeks. Chronic cerebellar ataxia, FA, SCA 1,228, MSAC. ICERS. Positive effect was predetermined to be an improvement in the ICERS of 5 points, 100-point scale. Riluzole 40 patients with cerebellar ataxia. SCA, FA, FXTAS, sporadic ataxia, MSAC, anti-GAD antibodies. Significant improvements in total ICERS, subscores for static function and kinetic function and dysarthria. 4 mild adverse events. Serotonergic drugs. Trias et al., 1988. Double-blind, controlled trial to evaluate the safety and efficacy of L5-HTP in ataxic patients. Inclusion criteria. Inherited and acquired ataxia, LOCA, cerebellar atrophy, FA, infarction, MS. Dose, 10 mg/kg/day of L5-hydroxytryptophan. Resulted in significant improved scores in upright standing, speed of walking, and speaking. Buspirone. Liu et al., open-label study of buspirone showed benefit in treating ataxia. Trias et al., 1997, DB, placebo-controlled trial, patients with pure cerebellar cortical atrophy, 1 mg/kg. Excluded ponton involvement. Significant improvements in standing with feet together in one place. No other improvements, deemed clinically minor. MJD not responsive to treatment, buspirone. Asadi et al. Double-blind, placebo-controlled randomized trial in SCA 1,2, 3, 6, FA, DRPLA. Buspirone 30 mg/day or placebo for 12 weeks. ICARS, 1 dropout. No difference in total ICARS scores between groups. No comment on subscores in the ICARS. Dandospirone. Dandospirone, Sadiel, is an anxiolytic and antidepressant used in China and Japan. Dandospirone acts as a potent and selective 5-HT1E receptor partial agonist. It is closely related to other agents like buspirone. Thyrotropin-releasing hormone. Thyrotropin-releasing hormone. Thyrotropin-releasing hormone, TRH, affords some improvement in cerebellar ataxia in Japan. Improves cerebellar perfusion in patients with spinocerebellar degeneration. The beneficial effects of TRH may be due to increased cerebellar RCBF, or the increased RCBF may be a secondary effect of TRH therapy. Thyrotropin-releasing hormone. Sobu et al. 1983. 290 patients with SCA. DB, randomized, placebo-controlled trial. SCD. Qualitative scales. MTRH 2 mg, half a milligram or 0 mg once a day for 2 weeks. Improvements in treatment group compared to placebo. Taltirelin Shirasaki et al. 2003. 10 MJD patients treated with taltirelin. Analyzed by a voice recorder. ICERS did not change, but improvements noted in speech. Antioxidants. CoQ10. Idebanone. A0001, Epi 743, coenzyme Q10. Function as cofactor in mitochondrial electron transport chain. in reduced form, ubiquinone, as an antioxidant. Studies with CoQ10 and vitamin E have met with limited to no success, PD, Fa, etc. They can be limited by transport proteins, oral absorption. A001, Epi 743 Edison Pharmaceuticals California. A001, alpha-tocopherylquinone. Being tested for FA, Mellis, Lees disease. These diseases involve the mitochondrial respiratory chain causing oxidative stress. Can these diseases be treated with antioxidants? A0001, Epi 743. Granted orphan status by United States FDA for inherited mitochondrial respiratory chain diseases. A0001 is structurally similar to CoQ10. Differs in its pattern of chemical substituents of the p-benzoquinone ring system. A0001 has more favorable redox potential than CoQ10. Expected to mitigate against mitochondrial oxidative stress. Protect against lipid peroxidation. Facilitate electron transfer in a dysfunction respiratory chain. Indole 3-propionic acid, IPA/protocol 20629-100. A Phase 1, randomized, double-blind, placebo-controlled, multi-center, single and multiple ascending dose study to evaluate the safety, tolerability, pharmacokinetics, and pharmacodynamics of oral VP 20629 in adult subjects with Friedreich's ataxia, VP 20629. VP 20629, also known as indole 3-propionic acid or IPA, Cas 830-96-6, is a potent antioxidant with the potential to protect against neurodegenerative disease. It may inhibit iron-induced oxidative damage to hepatic microsomal membranes, Carbonic et al., 2001a. Possibly can prevent free radical membrane damage, Carbonic et al., 2001b. May also reduce oxidative DNA damage, Chi et al., 2000. Oral zinc sulfate. Cuban patients with SCA2 have reduced concentrations in zinc in serum and CSF. DB, placebo-controlled, randomized study by Velázquez Pérez. 6 months, zinc 50 mg/day. Treatment group had increased zinc in CSF, and improvements in gait, posture and stance, albeit mild. Intravenous immunoglobulin for antibody-positive cerebellar ataxia. Nanry et al., 2009. Patients who had autoantibody-positive cerebellar ataxia. 5 of the 7 patients had benefit after injection with IVIG 400 mg/kg/day. SPECT scans and videotapes. Patients who noted benefit were anti-GED positive and anti-gliadin positive. IVIG. Following IVIG treatment, there was approximately 40% reduction in serototal score, and a 10 to 20% mean improvement in spatiotemporal gait parameters, including gait velocity and stride length during comfortable walking. The greatest improvement was generally noted after the 3rd course. Improvements in gait, SARA subscore, oral motor action, and speech, PADA, were observed. Clinical improvements persisted for 28 days after the final infusion, but attenuated by 56 days after the last infusion. Acetazolamide. Griggs et al. Reported that acetazolamide could improve the episodic symptoms of episodic ataxia type 2. EA2. Autosomal dominant disorder characterized by ataxia, vertigo, nystagmus and fatigue. Jen et al. Noted that acetazolamide did not improve chronic ataxia, but episodic symptoms of SCA6. 3,4-diaminopyridine 3,4-DAP is a potassium channel blocker. Tsunami et al. 2010, 10 patients with SCA6 and 5 patients with chromosome 16q22.1 linked autosomal dominant cerebellar ataxia received 3,4 DAP. 20 mg BID. 3,4 DAP significantly reduced DBN, but other ataxia symptoms did not improve. Histone deacetylase, HDAC, inhibitors increase frataxin expression by decondensing abnormal chromatin structure at the frataxin gene. 2 novel DAC inhibitors with pamelic diphenylamide structure were effective in upregulating frataxin in lymphocytes of FRDA patients and a mouse model of FRDA. Pioglitazone. FRDA mouse model showed that metabolic pathways regulated by peroxysoproliferator activated receptor gamma, PAR-gamma, are dysregulated. Pioglitazone, anti-diabetic PAR-gamma agonist that is being tested in trials in FA. Transcranial magnetic stimulation and surgical trials. Transcranial magnetic stimulation. Shimizu et al. Used TMS for 4 patients with SCD, SCA6 equals 2, SCA1, and SCA7. 10 consecutive pulses over right, middle and left cerebellar hemispheres every day for 21 days. Improvement in gait, timed and tandem. No changes in dysarthria or upper limb in coordination. Increased blood flow to cerebellum, putamen and pons. Deep brain stimulation. MSAP cases. Very transient improvement with DBS, STN. Several cases reported death after DBS implantation. Natural history study of SCAs 1, 2, 3, 6 and 7, Dr. Tetsuo Ashiizawa. Physical therapy and SCA. Exercise on brain function. Therapeutic effect of dalfampridine on gait in coordination in spinocerebellar ataxias, a randomized, double-blinded, placebo-controlled, crossover clinical trial. Other research biomarkers: pluripotent stem cells. Other stem cell possibilities. Optimization of varenicline doses for treatment of SCA3. Develop internet-based sensitive and reliable disease measures. Cognition and emotion in patients with spinocerebellar ataxias 1, 2, 3, 6 and 7. Issues with clinical trials. Issues with clinical trials. Many different medications tried in various etiologies of ataxia. The story is similar, a few case reports show promise. Subsequent randomized trials yield conflicting results. A negative result from a controlled trial can hide possible positive effects of a therapeutic agent for many years. Reasons for non-reproducibility. Patient selection. Lack of choosing patients between SARA score of 10 and 20, for example. Most patients who were selected suffered from several different types of ataxia: sporadic, MS, stroke, post-surgical, infectious, as well as hereditary ataxias. Uniformity in patient selection, SCA3, SCA1,2, or episodic ataxia, for example. Reasons for non-reproducibility. Autosomal dominantly inherited ataxias, along with other forms, are characterized by many neurological symptoms. It is important to formally characterize these neurological symptoms as a baseline. This will improve patient selection. At study conclusion, will help to interpret results. Will identify which symptoms are being treated. Comparison between Parkinson's disease and spinocerebellar ataxias. Extrapyramidal system. Bradykinesia. Rigidity. Tremor. Postural instability. Non-motor symptoms. Dysautonomic. Symptoms can include ataxia, neuropathy, spasticity, motor weakness, dysarthria, ocular problems, Parkinsonism. Dystonia. Widespread and various neurological symptoms in SCA. Parkinson's disease. Spinocerebellar ataxias. Symptoms, 1 chapter in the neurology textbook. Symptoms, 6 chapters in a neurology textbook. Ataxia. Neuropathy. Motor weakness. Spasticity. Ophthalmoplegia. Dysarthria. Parkinsonism. Dystonia. Axial or appendicular. Of the Cerebellar may differentiate and report on improvements in either axial or appendicular function. The work on Buspiron by Truyas et al. Demonstrated improvements in standing with feet together, but not appendicular function. Varenicline, Class II improvement in axial function, but only one measure improved consistent with appendicular function. Reproducibility. Scales, need to differentiate between axial function and appendicular function. Some studies found improves in standing time, while others simply reported findings of the total score.